This video demonstrates how to draw up epinephrine and volume expander and administer them through an emergency umbilical venous catheter. Epinephrine is indicated if the baby's heart rate remains less than 60 beats per minute after at least 30 seconds of PPV that move the chest, preferably through an alternative airway, and another 60 seconds of chest compressions coordinated with PPV using 100% oxygen. Epinephrine is not indicated before you have established ventilation that effectively inflates the lungs. Since May 2016, manufacturers have been required to label epinephrine as 1 milligram per 10 milliliters, not 1 per 10,000. Be sure you have the right concentration of epinephrine for newborn resuscitation, which is 1 milligram per 10 milliliters. You'll also need a 1 milliliter syringe for IV administration and a 3 or 5 milliliter syringe for intratracheal administration. These two different sizes of syringe serve as a visual reminder that epinephrine has two routes and two different doses. The 1 milliliter syringe is used for the smaller IV dose, and the bigger syringe is for the larger dose. You'll also need a 3-way stopcock or a fluid dispensing connector, medication labels, and something to write with. It's helpful to keep the epinephrine, syringes, and the stopcock or the fluid dispensing connector rubber banded together so that the medication person does not need to remember what supplies are needed. Let's prepare IV epinephrine. Let's imagine the medical provider has ordered 0.6 milliliters epinephrine, 1 milligram per 10 milliliter concentration for the UVC. Be sure you have the 1 milligram per 10 milliliter concentration of epinephrine. Open the perforated end of the box. Remove the two pieces inside. Holding the devices with the yellow caps on top, flip off the yellow caps and screw the two pieces together. Attach the 3-way stopcock and connect the 1 milliliter syringe. Turn the stopcock off to the unused end. This opens the stopcock between the syringe and the medication. Give the epinephrine vial a push and fill the syringe. Remove the epinephrine from the stopcock. Ensure that there are no bubbles in the syringe. Ensure that you have the correct amount of epinephrine in the syringe, which is 0.6 milliliters in this example. Now let's repeat the procedure using the fluid dispensing connector. Connect the fluid dispensing connector to the epinephrine vial. Attach the syringe to the connector and push the epinephrine into the syringe. Detach the epinephrine and ensure that there are no bubbles. Check your hospital policy for labeling code medications. If you set the syringe down or hand it to someone else, you should label it. Position the label so you can see how much epinephrine is in the syringe. It's every team member's responsibility to call out a possible patient safety issue. For example, if the epinephrine is in the wrong size syringe for the route. Any team member may ask for clarification by saying, for example, "Stop. The IV dose is in a 5 milliliter syringe. Is that correct?" The team should stop administration and double-check the route and dose of the medication. Now let's administer a dose of epinephrine for the UVC. The medical provider and the medication nurse use closed-loop communication to order and administer the medication.
Cheryl, this baby is approximately 3 kilograms. Please draw up 0.6 mLs of epinephrine, the 1 milligram per 10 ml concentration to be given via the UVC.
Okay. I'm preparing 0.6 ml of epinephrine, 1 milligram per 10 ml concentration for the UVC.
That's correct.
Prior to giving the epinephrine, the order is confirmed using closed-loop communication.
I have 0.6 ml of epinephrine for the IV.
That's correct.
Ensure that the catheter is being held in place. Attach the syringe to the stopcock. Open the stopcock to the catheter and syringe, aspirate slightly to remove potential air bubbles, and administer the epinephrine rapidly. Now turn the stopcock so that it's open between the baby and the normal saline flush. Gently flush the epinephrine through the catheter with 0.5 to 1 milliliter normal saline. turn the stopcock off to the baby. Now the recorder can acknowledge the intervention, document the time, and alert the team when 1 minute has passed. Continue coordinated compressions and ventilations for 1 minute before checking the heart rate. Use this minute to ensure that there is chest movement with PPV, that compressions are 1/3 the AP diameter of the chest, and that compressions and ventilations are coordinated at the correct rate. Make sure 100% oxygen is in use. Plan your next steps if the heart rate does not respond to IV epinephrine. You may repeat the recommended dose every 3 to 5 minutes. Check the heart rate 1 minute after epinephrine administration. Continue ventilation. Briefly pause compressions. Discontinue compressions if the heart rate is more than 60 beats per minute. Intratracheal epinephrine may be given while IV access is being established. However, the heart rate response may take longer or may not occur. Use a 3 to 5 milliliter syringe for intratracheal epinephrine and draw it up as previously described. The medication nurse has repeated the order by announcing the epinephrine concentration, dose, and route. The medical provider has confirmed the order. Disconnect the PPV device from the endotracheal tube and deposit the epinephrine. Reattach the PPV device and continue ventilations and compressions. The medication nurse announces that the epinephrine is in, so that the recorder can acknowledge the intervention, document the time, and alert the team when 1 minute has passed since administration. If IV access is attained after intratracheal epinephrine was administered, and the heart rate is still less than 60 beats per minute, it's not necessary to wait 3 to 5 minutes before giving the IV dose of epinephrine. If there is not a satisfactory response after IV or intraosseous epinephrine, consider other problems such as hypovolemia and tension pneumothorax. Volume expanders should not be given routinely during resuscitation. If the newborn is not responding to the steps of resuscitation and has signs of shock or a history of acute blood loss, volume infusion may be indicated. The initial dose is 10 milliliters per kilogram. The recommended solution for treating hypovolemia is normal saline. When severe fetal anemia is suspected, packed red blood cells should be considered. If cross-matched blood is unavailable, use emergency, non-cross-matched type O Rh-negative packed red blood cells. To administer normal saline, fill a 30 to 60 milliliter syringe with normal saline or use pre-filled normal saline syringes. The medication nurse takes the volume expander to the bedside and confirms the order. Volume expander is infused over 5 to 10 minutes by slow, steady push, or use a syringe pump. If the newborn is still not responding to resuscitation efforts, reassess the quality of your ventilation and compressions. Is the chest moving? Are there equal breath sounds? Is the airway obstructed by secretions? Is 100% oxygen in use? Is compression depth 1/3 the AP diameter of the chest? Was the correct dose of IV epinephrine given? Is it time to repeat the dose? Is a pneumothorax present? A stat chest X-ray may provide valuable information. If necessary, call for additional expertise. Be sure to provide support for the baby's family.